Hello, this is Optimum Health For All. I'm your host, OJ Odia.
Optimum Health For All, for all, for all. We're building up strong so we never fall. Mindset, power, we're standing tall. It's Optimum Health, yeah, it's for all.
Today, we're going to talk about some advances in the management of cardiac disorders. And we're going to concentrate on rhythm disorders, but that would mean abnormalities of heartbeats, heart beating irregularly, and so on, and what we can do to manage them. I will not talk much about it because we have an expert in the studio, Dr. Grubb. Dr. Grubb, you are welcome. So can you tell us a little bit about yourself, what you do? Can see you are scrubbed up. Why are you in Nigeria? What do you do? And what else do we want to know about you?
Well, thank you for having me. So I'm Dr. Neil Grubb. I'm a cardiologist from Edinburgh in Scotland in the United Kingdom. And my special field is the management of heart rhythm disorders. And in my home country, I deal with patients with rhythm disorders every day. I see them in clinics and I put them through treatments. And I would divide these treatments into two different groups of heart rhythm disorder. So we deal with patients with abnormally fast heart rhythms, so their heart beats very rapidly, and that can make them feel very uncomfortable and unwell. Some of these rhythms are also quite dangerous to the person that I'm seeing, and in some cases these rhythms can endanger their life. The other group of patients are patients who have abnormally slow heart rhythms, so that is where there is some kind of problem with the transmission of electrical impulses through the heart, causing a slow rhythm that we call bradycardia. And the symptoms that you get from the fast rhythms and the slow rhythms are very different to each other. And one of the things I'd like to touch upon is the recognition of these rhythms and the symptoms that you get with them. Because certainly in the UK, we know that there are many people in our population who have problems with the rhythm of their heart, but just don't recognize it. They don't know what symptoms to look out for. And I'm sure the same is true here in Nigeria. So the symptoms that are associated with a fast heart rhythm would be a feeling of palpitation in the chest. And what we mean by palpitation is a feeling of a very forceful heartbeat, or a very rapid heartbeat, or an irregular heartbeat. And so the sensation is quite intense in the chest, and the person may feel their heart beating very, very rapidly indeed. Often this comes on quite suddenly, and there can be other symptoms that go along with it, sometimes tightness in the chest or lightheadedness. So that's what typically a person would feel if they had an abnormally rapid heart rhythm. For slow rhythms, it's rather different. The palpitation doesn't tend to happen so much, but because the heart slows down, it doesn't pump as much blood as it should do up to the brain. And so what happens is the person will feel very lightheaded when the heart is beating slowly. And if the heart goes slow enough, then it can actually cause the person to black out or lose consciousness. And that's quite serious because that can cause injury. It can cause head injuries. And in older patients, it can cause them to break their hip, break their leg, and then that causes disability. Now, the thing about these rhythm disorders is that they're treatable. And they are treatable not necessarily with the highest of high-tech medicine. So the key, though, is recognizing the problem in the first place. And I want to talk a little later during this interview about what tools can be employed to make a diagnosis of a heart rhythm disorder and treat it. Coming back to you asking me what I do, the one thing is diagnosing these rhythm disorders through patients presenting with symptoms like that and the tests that we have available. And then it's the treatments. Now, like all doctors, I prescribe medicines to treat heart disorders, and some heart rhythm problems will respond very well to simple medication, and that can completely settle the rhythm down. Some patients with abnormal heart rhythms are prone to blood clots and are at risk of having a stroke. And so for some of these patients, they need anticoagulant or blood thinner medications, which can make a big difference to their risk. But as well as medicines, we have some more practical technical procedures that we can do that are of great help. So for the rapid heart rhythms, that is the reason that I'm here in Port Harcourt, is to provide some teaching and training and some early exposure to the doctors, nurses and physiologists to a treatment called catheter ablation. And what that involves is passing long flexible wires or catheters from the vein at the top of the leg, through the veins in the tummy and the chest, and up into the heart. And we can make heart recordings from the inside, and we can work out what the source of somebody's rapid heart rhythm is, and then use heat treatment, we call that ablation, to get rid of the short circuit or the abnormal tissue that's making that person's heart beat very quickly. And so far we've treated 7 patients. I'm just out of the theatre having treated a patient successfully for a heart rhythm condition. So catheter ablation is a relatively new treatment here in Nigeria. It's a well-established treatment in the UK and in other countries in Western Europe. And it's something that ideally I think we should bring more of to your population. For the slow rhythms, there is no medicine that can cure that, unfortunately. We don't have any medicines that speed the heart up without causing really bad side effects. So we have to have a different approach in people who have an abnormally slow rhythm. So we have devices which stimulate the heart. These are implantable devices called pacemakers. And what a pacemaker is it's a small, flat metal device. It's a few millimeters thick, and it's connected to 1 or 2 flexible wires or cables that are run through the veins and down into the heart itself. And when the heart is beating too slowly, the device can detect that and automatically stimulate the heart to beat at a normal rate. The technology's been around for a long time for this, but it's gradually become refined, and the costs have come down quite a lot. It's a very cost-effective treatment in terms of the upfront cost of the treatment versus the number of years of benefit that the person will get from it. So if we implant one of these pacemakers, the cost of a new pacemaker may seem quite a lot, quite expensive, but your average patient will get 12 years of good quality of life from that pacemaker. And without it, firstly, the quality of life would be very poor. And secondly, for some of these slow rhythms, there's a real risk of the heart stopping altogether and of that person dying suddenly of the heart disorder. So we have to think of ways of bringing that technology in a more affordable way into somewhere like Nigeria. I'm pleased to see that the pacing practice has become better and better established in these pockets of excellence that you have in Port Harcourt, in Abuja, and in Lagos. And we're hoping that these are the nuclei from which you will gradually expand
to the rest of the country.
Exactly.
Okay. So, thank you very much for what you do and what you have done.
Thank you.
So you are basically on a mission. That is, it's a missionary type of service. That is sponsored by a foundation, isn't it?
That's correct.
Okay. So for us, we are benefiting from your expertise, and it's basically like most of the patients who are lucky enough to get into this program is almost free of charge.
Yes, that's right.
So I know that for others, if this was not a mission and it was not being funded by a foundation, people will have to pay out of pocket.
That's right.
So that is where cost of these devices come in. But you're saying that it is the hope that in future the cost will come down because more people
Yes,
will be available to more people.
exactly.
So when the cost come down, maybe common people, persons like me and others will also benefit from these devices if we do need
Yes.
those devices. So how do you make a diagnosis of reading disorder? Say reading abnormality. How is the diagnosis made? First, how do the patient know that they have these problems?
Yeah. So the patients would know they had these problems through the symptoms I described earlier in the interview. So for those with the rapid heart rhythms, palpitation, chest discomfort associated with it, a feeling of an irregular heartbeat. And for those with slow heart rhythms, then they may feel suddenly lightheaded or they may actually black out. But there is quite a large population of patients who have rhythm problems that are more subtle. So the symptoms are less obvious to the person. And that's where having access to being able to screen for rhythm disorders becomes important. So how do we make a diagnosis of an abnormal rhythm? Well, the simplest thing is to feel a person's pulse. And that's something that any medical facility can do. And that will tell you if the heart is beating regularly or not. And it will tell you how quickly the heart is beating. And below a certain level or above a certain level of heart rate, you might become suspicious of a rhythm disorder. The basic diagnostic test is the ECG, the electrocardiogram. And an ECG is fairly simple to record, and access to ECG is surprisingly difficult in some areas. And it's true in Scotland, where I live as well, in more remote and rural areas. If a patient has symptoms, it can take a long time for them to find a facility where they can have an ECG recorded. And I've been very interested in this in my practice in Scotland. And one of the things that I've been doing over the last few years is screening the general population for rhythm disorder. And we did a research study looking for a rhythm disorder called atrial fibrillation, or AF, in the elderly population. Now, by elderly, I mean over the age of 65. So I'm approaching elderly now. But people over the age of 65 who had risk factors for heart disease, like diabetes or high blood pressure, or they had a strong family history of heart disease. And we provided them with a very simple tool that they could use with the phone to diagnose an abnormal heart rhythm. And it's possible now to record a simple ECG on your phone if you have a little device that adapts the phone. Now, it's becoming very common to own a smartphone, and most young people now have a smartphone. And this device is very cheap, and healthcare centres could afford to buy one or two of these devices and give it out to a patient for a week or two at a time. And if the patient has symptoms, they can learn to record an ECG themselves. They can practice when they don't have symptoms and have a look at the trace on their phone and make sure they're making a good trace. And these single lead ECG recorders, they're becoming more and more common and quite cheap, really, and much cheaper than the commercially available medical ECG recorders, if you like. So we screened more than 2,000 individuals aged over 65 years using this simple technology. These were people who were coming to their healthcare centre for a blood pressure check or for their vaccinations in the winter. And the practice nurse would show them how to record an ECG. They'd record it, and the ECG got sent through to me. And of those 2,000 patients, 4%, so that's 4 in every 100, had this rhythm called atrial fibrillation, and they didn't know they had it. They had no symptoms from it. And in people over age 65 with this rhythm, they're at real risk of having a stroke because of it. And we were able to identify that and prescribe them the medication that protected them against the risk of stroke. So that's one example of how you can use new technology, smart technology, if you like, to diagnose rhythm disorders. Increasingly, we have wearable devices like Fitbits. Some people have Apple Watches or Samsung Watches, although they're quite expensive. But the trickle down of this technology is that I believe over time, we'll all be wearing something on our wrist that can record an ECG, that can record the rhythm of the heart. So educating the public in knowing what the symptoms are of an abnormal heart rhythm is really important. And that's where public health campaigns come in. And I don't know if there's a mechanism here in Nigeria where you can broadcast that information.
People, this is one of it. And I mean, this is my own effort to do health education, public health, awareness, and so on. But there are others. There are people on TV, radio, the government services, health services, they do that. In fact, they have public health units in most of the state and federal ministries, whose responsibility it is to give public awareness. But we concentrate, as it were, because that's a major problem, on communicable diseases. Like Lassa fever, mpox, and so many others. COVID-19, when it was a big problem, and so on.
And we have these public awareness campaigns in the UK as well. So we have campaigns getting people to recognize the signs of a heart attack, knowing to call for help immediately if they have previously, they have chest pain where they've not previously had that symptom. So an unexpected sudden chest pain, call for help straight away. Other campaigns to help the public recognize the signs of a stroke so they can access stroke care quickly.
Go to hospital.
And so you could have a similar campaign for recognition of a heart rhythm problem. So educating the public is important because it's hard to get an ECG recorded unless you know that you need an ECG recorded in the first place.
And then for you to read and be able to interpret it. And then get it to a doctor to look at.
But that's another interesting point because we have AI available now. We have technologies that can do a basic interpretation of an ECG without necessarily the physician having to look at it. So for the device I was using, which is called Cardia, the Cardia software interprets the ECG for you or for the patient, and it will flag up on their phone normal ECG or suspected atrial fibrillation. And if the phone says normal, that means normal. If the phone says suspected atrial fibrillation, it might or it might not be a rhythm problem that the person actually has, but at least flags that they need to get that checked out and have a proper full ECG recorded to figure out whether that's the
So when this diagnosis is made, patient is brought to hospital, there's drug treatment. Okay, and then for most people, the drug treatment should be sufficient.
That's right.
Okay, so when do we now use ablation, for example? When do we really think that we need to have cardiac ablation? When, especially with these patients that have rhythm abnormalities, how do we say this person should have an ablation done, or this patient can stay on medications?
So when I started as a heart rhythm specialist, and I've been in this field for a long time now, I started training in cardiology in 1993 and became interested in rhythms a couple of years later. And catheter ablation was a technology in its infancy. Back then.
I remember it was used for your former Prime Minister.
Exactly, Tony Blair. That's right. And he has never had that rhythm problem again.
Anymore.
But back then, catheter ablation was only used if drugs failed. And the technology was quite crude back then. And I'll be honest, we weren't very experienced at doing the treatments either. And the technology has evolved beyond recognition over that time. But I think the other key thing is that those of us who practice catheter ablation have got better at it. It's like everything that's practical in medicine. The more you do it, the better you develop your skills.
Yes.
So I was doing a handful of procedures every year back then. I now do 250 catheter ablations a year in my own centre, so 5 or 6 procedures a week. And so your skills get good when you do
much
that
better
kind of
and
thing.
better. Yeah.
So we've gone from that situation 25 years ago where a patient would only get an ablation if you tried all the different drug options first, to a situation now where for certain rhythm disorders, catheter ablation is regarded as first line. Yeah.
Just go in and remove it.
There are other rhythm disorders where the ablation process is more complicated and higher cost, and where the risks are a little higher and the aftercare more complicated. So, for example, ablation for atrial fibrillation, we're further back in learning the best way to do that. And it can be a very effective treatment, but there are also some patients who don't respond. And the risks are a bit higher the more complicated a procedure gets. So for atrial fibrillation in most places in Western Europe, patients would be tried with drugs first, and if they continue to have a lot of symptoms despite the drugs, or if the medication was causing significant side effects, then the next step would be an ablation treatment. For patients who can afford it, some patients are now coming to us with atrial fibrillation saying, I don't want medication, I want an ablation,
yes,
and I'll pay for it. And that's in the private healthcare sector. I don't work in private healthcare. I just work for the National Health
Service. So you work for government?
Yes.
And most of the treatment is free to the patients?
It's free at the point of access. So we all pay our taxes. The taxation is quite high in the UK,
I know.
particularly if you are in my bracket of earning.
Mm-hmm.
But the benefit to society is good because the higher earners...
So you don't have to pay a premium?
No, you don't have to pay a premium.
So everybody, so long as you're a citizen or a resident, and you are paying your taxes, you're entitled to free healthcare.
Yeah. Okay. And even people who don't pay taxes are entitled to healthcare. And that's society that we live in. And it's good because you don't see people being significantly disadvantaged because they don't have very much money.
Yes.
Some people resent it. Some people who earn a lot of money resent paying
why are you using my money to look after those people who are not paying tax? But the elderly don't pay tax. Those who have retired, they don't pay tax.
Yes.
But they're entitled to...
They pay tax all their life. But there are some people who have not had the opportunity to get into employment because of health problems or social problems.
They too could be supported.
And they're supported. And I think that's good. But that's... For the more complex rhythm problems, then that's the situation. But there's an opportunity for simpler rhythm problems, and these are the ones that we're treating here in Port Harcourt during the mission, which you mentioned a sponsor, which is the Cardiovascular Education Foundation. They do a great job of coordinating for us, and they cover some of the administrative costs of the mission, and we give our time to come and teach. But the patients we've treated have simpler rhythm disorders. One is called supraventricular tachycardia, or SVT, and that's quite a common rhythm disorder among young people. And it's a cause of uncomfortable, unpredictable palpitation in those folk. Another related condition called Wolff-Parkinson-White syndrome, and that can also cause rapid palpitation, and in some cases present a real danger to the person who has the condition. Now, these conditions are more easily treatable with catheter ablation, and the catheters we use are lower cost, and there is actually the potential to reuse catheters between patients as long as they're properly processed. And in the UK, actually, and in Europe, there are companies that will reprocess catheters so that you can use them again at a lower cost. And that's actually what we're doing here during the mission, is that catheters that otherwise would be thrown away after one use are being put to better use.
Yes.
They still function very well. We've had no problems with the reprocessed catheters that we're using here. And that's one way of allowing us to do some of these treatments. So for those patients with SVT and Wolff-Parkinson-White syndrome, I think ablation is a first-line option in the UK. I think it would be hard to make it a first-line option with the available resources in Nigeria just now, because there are only 2, possibly 3 centres who could potentially run an EP, an electrophysiology lab. So that's the environment that you need to be able to carry out these procedures. So in Port Harcourt and in Lagos, certainly, there's an environment where that kind of care can be delivered. But relative to the population you have,
it's just a drop.
We can't do it.
It's a drop in the ocean.
And you mentioned the mission coming and the patients being fortunate to be offered treatment on the mission. That's very true. But the purpose of the mission is not really to provide healthcare. We can't provide a health service here on a mission basis. It's great that the treatments we deliver are benefiting the people we see. And when you see these individual patients one-to-one before and after their treatments, that's the satisfaction of medicine wherever you come from. But that's not the main purpose of the mission. What we're trying to help do is help develop the skills and therefore the infrastructure so that local Nigerians can deliver it.
Okay.
So the main purpose of the mission is teaching and training. And so the charity is sending teams out every few months to Port Harcourt and also to Lagos and at times to Abuja as well. And we have identified individuals who require training, who hopefully will become independent operators in the future and be able to deliver these treatments. So that's one side of it, is training. And you know what's been great about coming to Port Harcourt this time and also a year ago when I last came is how impressive the standards of medical training are. You teach medical students to become excellent junior doctors, and you've got a really, really well-developed medical education program. And the problem is that the opportunity to put that into practice is sometimes limited. So the challenge here is how we make these higher technology treatments affordable and available in Nigeria. Yes. So how do you do that? Well, thinking about cardiac devices, the way we get cheaper devices in Edinburgh is that we are a high volume centre. So we do a lot of procedures. We implant more than 1,000 cardiac devices.
So we can buy a lot.
So we've got purchasing power. And there are 5 companies who manufacture pacemakers worldwide. And those companies are competing against each other for a share of the market. So we put our business out to tender. We tell them what we want, and the companies make an offer for the cost of their devices if we commit to buying them over 2 years. And so actually, compared with virtually any other country in Western Europe, because we have a national health service that can buy really in bulk, we get the cheapest prices in Western Europe. Unfortunately, with devices being bought in very small numbers in Nigeria, you don't have that clout at the moment. You don't have that purchasing power. But as the service develops, what I think could be considered as a model would be to have some kind of central purchasing. We call our department the National Procurement Department. They have people who produce the contracts, who get the bids in for the companies that provide the devices and then purchase. Because if Port Harcourt and Abuja and Lagos buy a handful of devices at a time, a few times a year from these companies, they're not going to get low cost. But if you had a central department that said, okay, we're buying for the whole of the country, and then we'll distribute the devices, that would be one way of getting new devices available at a lower cost. But that's still quite expensive. The other idea is whether you can reprocess pacemakers in a way that they can be reused. So there are two potential sources for that. One is pacemakers that have been bought by centres like ours, but which have not been used. And they have an expiry date, and the expiry date doesn't mean that on that date the pacemaker stops working.
Yeah.
What it means is that the sterile packaging that the pacemaker is made in can no longer be guaranteed by the company.
So you can re-sterilize.
So you can re-sterilize the device. Okay. The other source is devices that have been removed from patients because they've needed to have their device changed for a different type, because there are many different types of pacemaker. So pacemakers are sometimes removed when they have 90% of their battery still left. So that could still provide 10 years of good function if that device could be re-sterilized and reconditioned. So now that is possible, and that kind of pacemaker reprocessing has been done, and through a clinical trial that's been carried out here in Nigeria, it's called My Heart, Your Heart. That trial has looked at implant outcomes for patients who have received their reprocessed pacemakers. And we're interested in two things. Number one is when we reprocess the pacemaker, let's be 100% sure that's not an infection risk to the person receiving the pacemaker. And of course, with proper sterilization and reprocessing, that's not going to happen. The second thing is that reprocessing doesn't affect the electrical function of the pacemaker, that device isn't going to malfunction. Yeah. And it was great to see the outcome of that trial, which was very favorable, that the infection rates were no higher than if you had a brand new pacemaker implanted, and that the pacemakers functioned very well over the follow-up period. So that's another way of providing access. So that can be done for pacemakers. For the ablation procedure, we're using catheters that have been re-sterilized after a single use. And in fact, they are re-sterilized at the end of each day and used again and again and again.
Even in developed countries, they sterilize catheters, so it's not a big deal.
Yeah, and it's not a big deal. And in fact, when I started in cardiology in Edinburgh, we used to re-sterilize catheters, but then bureaucracy got in the way. And I have to be frank and say that I think that the medical industry, in some ways, applies pressure that devices are single-use or labelled single-use, because, of course, more can be sold if they're branded as single-use. But the reality is that we are throwing away every day perfectly good equipment.
In fact, even drugs too, they say they expired. Really, many of them have not expired.
Yeah.
Okay.
So it's a bit more difficult with drugs because we do know that drugs can lose their potency over time.
Yes, and then half-life becomes a problem.
Yeah.
So thank you very much, Dr. Neil Grubb. I'm sure we have benefited a lot from you.
Thank you very much for having me.
Thank you for coming. Thank you for what you do and all the good things you have done for us in Nigeria, and I'm sure elsewhere in the world that you have been to. Thank you very much. And viewers, Optimum Health For All, thank you for staying with us, watching our episodes of this podcast, and we hope that you have enjoyed this program and benefited from this program as much as I have done. Thank you for coming. Please subscribe, share this video to as many people as possible. Bye for now.
Optimum Health For All, for all, for all. We're building up strong so we never fall. Mindset, power, we're standing tall. It's Optimum Health, yeah, it's for all. Knowledge is wealth, so we pass it on quick. From the food to the mood, we be flipping the script. From gut to brain, everything aligned. When you live that good life, it's a powerful sign. Power is the mission, got the vision on deck. Cut the stress, no mess, keep the wallet. wellness in check, and we thrive, we shine with every routine. Optimum health, you know, but optimum health for all.